Hello, my name is Dr. John Odette. Today I'll be presenting a case of inferior zonulopathy in a patient with a long-standing history of Marfan syndrome. As you can see, to start the case here, the lens has already been fragmented and a capsulotomy already performed with the LenSx laser. You can also see the inferior zonulopathy present at approximately 9 o'clock in the video. I'm making my paracentesis stab incision in the area of that zonulopathy, and then I'll proceed to open the primary incision with a Donnenfeld flap applanator. This is was also made by the LenSx laser. At this point, we've got a fair amount of viscoelastic in the eye already, and I will perform removal of the capsular rhexis using a simple Utrata forceps. You can see this was a free-floating capsule, came free quite nicely. Makes the capsular rhexis much easier in a case of Marfan's. Next, we perform hydrodissection, and I perform a very gentle hydrodissection here. Normally I go 180 degrees opposite the wound and spin the lens, and that's it. But in this case I wanted to ensure that the hydrodissection and hydrodelineation, which was performed in this case, was quite significant, so I would not put any additional stress on the zonules as we're trying to spin this lens. You can see I do 3 to 4 fluid waves here. The lens starts to prolapse forward out of the bag, so I push it back with my chain cannula. My preferred technique in these cases is somewhat of a phaco chop, since the lens is already fragmented. Here I'm just using a little IA with the phaco handpiece and doing very gentle segmentation of this lens. You'll see it cracks very easily with very little power from my ultrasound. Now, I do rotate these lenses, and I rotate them from the superior aspect to the inferior aspect, so I'm actually trying to rotate toward the zonulopathy instead of away from the zonulopathy. This helps prevent any further tearing of zonules or stretching of the current zonules that she has. Here you'll see that I fragment a quadrant out, and then I'll slowly remove this segment using the segment removal form of my phaco emulsification. Once I get one quadrant out, this lens moves a lot more freely. I am a little more free to be a little more assertive with this lens, because I'm less concerned about stressing out the bag and zonules. But I do use kind of what I call a low and slow fashion to remove this lens, meaning my bottle height was lower than average for me, and I perform this removal very slowly. At this point I just wanted to ensure that the anterior chamber was going to be stable, so I did reinflate the bag with viscoelastic. I like to avoid any vitreous prolapse around the loose zonules inferiorly, so I did reinflate the bag there. Next we'll finish up by removing the remaining portion of this lens. As I mentioned before, I do this in a very slow, deliberate fashion. I don't want to put any additional stress on the bag, as I previously mentioned. So once again, this lens has already been fragmented by the LenSx laser, so it does segment quite nicely. I'm using very little phaco power here. This lens was about a 3+ nuclear sclerosis. It was not a white mature cataract, but it was fairly dense, and so we did use a little bit of phaco power here. Normally, if I had more concern about the capsule, I would chop this more vigorously, but at this point I could tell that the capsule was still very stable, so I was just letting my phaco handpiece do the work and ensuring that the capsule was stable using my second instrument. At this point we've just got a couple little fragments left. I'm just going to IA these up, trying not to allow any tenting of or ballooning of the chamber at this point, so I'm using very little aspiration here and just kind of feeding the remaining pieces in to the phaco handpiece with my second instrument. Once I complete the cortex removal here, I'll go back in and reinflate the bag. If I would have had any concern over the stability of the bag, I probably would have reinflated prior to removing my phaco handpiece, but this bag was pretty stable. So now I'll go in and just IA. I start my sub-incisionally, and you'll see I proceed kind of superiorly and at the 12 o'clock position that I'm at now. Last, I'll try and maybe do a little IA where the zonulopathy is. I really don't want to do much there because it's very easy to yank the bag and tear it. And you can see I do grab just a little bit of bag there and it starts to pull, so I leave that segment alone and I finish up with some cortical removal here. Of course, I'll go back in and reinflate the bag with more viscoelastic. One of the things that's very important in these cases that I'll do in just a couple minutes here is lens epithelial cleanup of the anterior capsule. Prior to doing that, though, I did want to stabilize the bag with a capsular tension ring. This capsular tension ring comes preloaded and it's made by FCI Ophthalmics. It's a very good capsular tension ring. One of the things I would have done differently in this case, you can see I'm injecting it clockwise, and actually I'm putting a little bit more stress than I would have liked to on those inferior zonules. I would have preferred to inject this counterclockwise, but the bag did quite well. Now I am performing that lens epithelial cell cleanup on the anterior capsule. This will help prevent any capsular contracture in the post-op period. The secondary reason for injecting the capsular tension ring was also to prevent some capsular contracture. However, the primary reason for putting in the CTR was to stabilize the zonules, and in case I ever need to perform a lasso technique, if these zonules have any further weakening in the future, I will be able to quickly and easily lasso that capsular tension ring and recenter the bag capsule lens complex. We are inserting a Tennis Toric astigmatism correcting lens here. Normally I position this with my IA, however I'm wanting to be as gentle as possible with this eye, instead use a simple collar button. This lens will be positioned at the inferior superior portion of the eye here, or the 3 o'clock and 9 o'clock positions in your picture. Finally, after I'm ensured that the lens is stable, I go back in, remove all remaining viscoelastic, and the lens is centered nicely and stable in the bag. This patient did very well. She was post-op 1 month out, seeing best or uncorrected vision of 20/20, and the lens was stable. Thank you for viewing this case.